I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke.
It's really important for the interventionist to know. We have three types of aortic arch. If you draw a line right at the lower end of the neck vessels where they are originating, and you draw a line at this level of the aortic arch, then if the origin of all the three vessels is above this line, this is a type 1 arch. If the brachiocephalic origin is between the two lines, this is type 2. And if the origin of brachiocephalic goes right up to the lower line or below this is the type 3 aortic arch, which is more difficult to engage if you come from the femoral approach. And But then you've got some dedicated catheters to engage this, or you can come from the arm approach for going into the carotid. Becomes much easier. So this is the information that you really need to know on the CT angiogram in advance before you move on to the cath lab for stroke intervention. So the best view to engage the neck vessels is the LAO view. Here you can see the aortic arch. This is the right brachiocephalic artery, right subclavian artery. Then you've got this right common carotid. This is the right vertebral artery. Left common carotid normally originates from the aortic arch. This is the left subclavian artery, and you can see the left vertebral artery going up. So that's the normal anatomy. But there are certain variants to it. One of the commonest variant is 27% is bovine arch, and what that is left common carotid artery arising from the brachiocephalic artery. So that's the typical bovine arch that you can see. So over here you can see the left common carotid again originating from the brachiocephalic. So this is bovine again. A radial or a brachial approach is much easier to engage this left carotid as compared to the femoral approach, but we've now have dedicated catheters which make life much easier. And then this is another variant where the vertebral artery is directly originating from the aortic arch rather than the left subclavian artery. Then we've got arteria luzuria, right subclavian artery originating from the distal aortic arch. Now this is something that we see during our angiograms as well when we go from the radial approach, and at times you find this arteria luzuria again shown here, arteria luzuria, and here you also have a common origin for the left common carotid and the right common carotid. Another variant where you can see all the four vessels coming from the aortic arch. Right carotid, right subclavian, left carotid, and left subclavian. All four are originating from the aortic arch. So common carotid artery divides into an external carotid and an internal carotid. How do you differentiate between the two? Internal carotid artery in its cervical course does not give off any branch at all. And the one that gives off branches is the external carotid. It gives branches to the face area. And then you can also see the first branch of the external carotid that goes downwards. This is the superior thyroid artery, and it is important when we do carotid interventions, especially if we use a proximal protection device called MOMA device, because the balloon of the MOMA, which is in the external carotid, should be occluding the superior thyroid artery. If it's a very low origin superior thyroid artery, then we may not be able to use MOMA for this because then you can't occlude this without occluding the internal carotid origin as well. But we don't need to go into those details. That I will discuss whenever we do the carotid intervention workshop. So internal carotid artery, no branch at all in the cervical segment. So the internal carotid artery then is divided into four parts. So you can see here, this is the cervical segment, which is the straighter segment. And then you've got the first bend, and this is the petrous part where it goes into the petrous bone. And then comes the cavernous segment, and then the last part, which is the superior clinoid segment. And then it ends by dividing into anterior cerebral and middle cerebral arteries. Same thing shown here, the cervical segment, then comes the petrous part, then the cavernous part, and then the supraclinoid segment, and that's the anterior cerebral and middle cerebral. Now, here what's important to understand is that where the supraclinoid segment starts, the last part before dividing into ACA and MCA, right at the junction of the cavernous segment and the supraclinoid segment, one branch comes off, which is the ophthalmic artery, and goes towards the eye, and the other branch comes off, which is the posterior communicating artery, and goes towards the backside. Two important branches where the supraclinoid segment starts. The importance we'll discuss when we come to the interventional aspects. Now, looking at internal carotid from another angle, this is the lateral aspect, this is the AP view, and in the AP view, you can very clearly see that the internal carotid artery terminates by dividing into anterior cerebral artery and the middle cerebral artery. So you can see here that's the internal carotid artery, number one, goes into anterior cerebral artery, and on the left it's the middle cerebral artery. This is the AP view. So middle cerebral artery then goes forward. The first branch that comes off it is the anterior temporal branch. You do not want to take your wire into this branch. It is small, it is fragile, it's easy to perforate. So you must know that anterior temporal artery is the first branch going down, and you want to avoid that. Then there are branches coming off from the M1 segment. This is the M1, which is the horizontal straighter segment arising from the ICA, and these are lenticulostriate branches which go to the basal ganglia, medial and lateral lenticulostriate branches. Then M1 is going to go and divide into two or three branches which are going to go into the sylvian fissure and go up right to the top of sylvian fissure. This bend where it starts going up is called genu, and up to this bend it is all M1. You can call it pre-bifurcation segment and post-bifurcation segment of M1, but from genu onwards, as it goes into the sylvian fissure right to the peak, this is M2 segment, and from the top of sylvian fissure when it starts going down, this is the M3 segment, and when it goes onto the cortical surface, this is the M4 segment. So these are the various segments of MCA. Now if you look at this blue diagram here, it's showing the same thing: internal carotid artery dividing into anterior cerebral and middle cerebral. Middle cerebral has an M1 segment, lenticulostriate branches going up. M1 segment then goes on to M2, which has two or three divisions. Up to the peak of sylvian fissure is M2. From there, when it goes downwards, it is M3, and on the cortical surface, it is all M4. This is an angiographic view. So you can see ICA again divides into anterior cerebral artery, goes up. On the other side, it gives the middle cerebral artery, which has an anterior temporal branch. It also gives off the lenticulostriate branches. Then it divides into the M2, M3, and M4 branches. It's important to again see here that right here where the supraclinoid segment starts, there is this branch coming off, which is the ophthalmic artery. This number 9 is the ophthalmic artery. Now there are variations in the MCA which are important to know. So the usual configuration is a horizontal M1 segment. So when you want to take your wire in, usually we put a loop at the end of the wire because we know it is going to go straight into the MCA M1 segment. Usually this is a very straight segment, and the loop keeps it protected from causing a perforation. So that's the straighter segment, but you can also have a segment like this which is superiorly angulated. So it's important to know. You can have a very tortuous sort of a segment which you can see in old age especially. So that's also MCA configuration. You can have an early bifurcation of MCA. Then you can have a duplicated MCA where both arise from the internal carotid artery. You can have a very prominent anterior temporal artery, which is indicated here. And it's important to realize that this is not an M2, this is just a prominent anterior temporal, and the M2s are here onwards. Now, on the lateral view, this is how it looks. So on the lateral view, this artery going up here and which goes like this is the anterior cerebral artery. And this all territory is what is occupied by the middle cerebral artery. And then if you look on the lateral view, this branch that goes like this is actually the inferior division of the M2. The M2 usually has two divisions, but it can have three also. So the superior division and the inferior division. The inferior division usually is the bigger one, and that is what we target and try to take our wire into. for doing all the procedure. That's our first effort. So on the lateral view, you can confirm whether you are into the middle cerebral artery inferior deviation or superior deviation. If you are going into this direction, you are in the inferior deviation. But if you are in this direction, you are in the superior deviation. Now, another way to look at it is that if you recanalize the artery and you find that this hole is opened up, but this space is empty, because there should be no empty space. Blood vessels are covering all aspects of the brain. So if this space is empty, this triangle, that means the superior division is still closed and the inferior is open. Whereas if this is revascularized and you have no vessel in this area, it means the superior division has been recanalized and the inferior division is still closed. Now, if I occlude MCA, suppose if I occlude MCA, then you'll see how the ACA looks. So this is how the ACA will look. If the MCA is occluded, you can see this is all empty space because the middle cerebral artery is missing. On the other hand, if I occlude the ACA, this is all middle cerebral artery, and the ACA is now occluded. This branch is occluded, and both are patent. This is the picture on the lateral view. On the lateral view, you will also appreciate that here you can see from the supraclinoid segment, that's the ophthalmic artery takeoff, and that's the posterior communicating artery. And again, you can see here, at times if you give a stronger injection, the through posterior communicating artery, you can even opacify the basilar artery, and you can also see the posterior cerebral artery. So the posterior circulation can also be seen if the circle of Willis is intact. You know that this is internal carotid, MCA, and here goes the ACA and then upwards. So the first horizontal segment of the ACA is called the A1 segment, and then as it goes up, it's A2, then A3, and then A4. And then you can see ACOM here. This is the anterior communicating artery, which completes the circle of Willis by joining the two anterior cerebral arteries of both sides. So this is the right and the left side. And on the lateral view, you can again see this is the anterior cerebral artery territory. And so this diagram I've shown you earlier. This is the complete, fully recanalized artery where there is internal carotid, and then that's the anterior cerebral artery going up, and this region belongs to the middle cerebral artery. And if you occlude the middle cerebral artery, then you can see the ACA alone, and you can see all the four segments and complete branches of anterior cerebral artery. Both vertebral arteries join together to form a basilar artery. When you look at your CT angiogram, you must see which one is the dominant or the larger diameter vertebral artery, because then that's probably your vertebral artery of choice to go into the posterior circulation. So the two vertebral arteries join to form a basilar artery, which then ends by dividing into the two posterior cerebral arteries. The posterior cerebral arteries give off very important branches here. These are end arteries that supply the thalamus. So then the basilar artery, and from the posterior cerebral artery, there is also a PCOM or posterior communicating artery that goes and joins the internal carotid artery, and this completes your circle of Willis, which we will talk about later. Now, basilar artery then gives off superior cerebellar artery on both sides. It gives off small tiny perforators here to the brain stem. Then there is an anterior inferior cerebellar artery, or what you call as ICA, and the vertebral artery gives off pica or posterior inferior cerebellar artery. Here the ICA can be seen dividing into a lateral and a medial branch, so two branches, big ones. That's why on the left the pica is missing. The vertebral artery is not making a pica because the ICA is actually covering for both. If you look on the lateral aspect, that's the vertebral artery forming the basilar artery going up, then the posterior cerebral artery, superior cerebellar artery, then the tiny perforators, then the ICA, then comes the pica, and anterior spinal artery originates from these two vertebral arteries. Again, looking at this angiographic view, the two vertebral arteries, the left one seems dominant. You can see the pica originating here. You can see ICA on both sides, tiny perforators on both sides, then the superior cerebellar arteries, and then the posterior cerebral arteries. Posterior cerebral artery, then again, like ACA and MCA, has a P1 segment, a P2, P3, P4 segment as shown here. But what is important is that this P1 segment is giving off tiny perforators to the thalamus. Similarly, these are end arteries, and similarly, M1 segment of MCA was giving off perforators to the lenticulostriate arteries to the basal ganglia, which was again end on arteries. So if you have a PCA P1 occlusion or an MCM1 occlusion, that is really bad because these are end arteries and uh, you do not get collaterals to these. If you have any other large vessel occlusion and if the circle of Willis is intact, you may not even get symptoms of stroke if you have good collateralization of that area. But for this M1 occlusion and P1 occlusion, there will be no collaterals. So you can have a bad stroke with these, and you really need to be quick in opening them up. Now, this is your circle of Willis. You have the internal carotid artery dividing into the anterior cerebral and middle cerebral artery, and from the anterior cerebral artery, you have an anterior communicating artery joining both side ACAs. Then you have a posterior communicating artery rising from internal carotid and going and joining the posterior cerebral artery, which is coming from the basilar artery. And this way, this is your circle of Willis. If this is intact, then you get collateralization of your large vessel occlusions. At times, if the circle of Willis is not intact, then it may not be possible. And that is what most of the interventions and trials have been focused on. But now we are also talking about MEVO. MEVO is the medium vessel occlusion, which means a distal clot. It could be a primary distal clot, which just goes and dislodges there, or it could be a secondary clot while we are taking clot out from the large vessel occlusion. A fragment of the clot breaks and it goes into one of the distal territories. So, what is MEVO? What is included in this? So, mainly anterior cerebral artery, then in the middle cerebral, the M2 to M4 segment. M1 was large vessel occlusion, M2 to M4 is medium vessel occlusion. Then the posterior cerebral artery, the pica, ica, superior cerebral artery, these are all included in MEVO. These are smaller vessel size and with severe loops and tortuosity, they have increased difficulty of successful navigation to target occlusions. Um, so patients with acute ischemic stroke are at risk, as I said, either primary or secondary distal occlusions. And for patients with disabling symptoms and proximal M2 occlusions, there is now expert consensus on the benefit of mechanical thrombectomy. Distal occlusions may lead to significant deficits because of the eloquence of specific branches. You do not need to chase every distal occlusion. You need to see what is the clinical deficit that this branch will cause. If it's an eloquent area, then you may need to intervene on this. But it's important to remember that distal occlusions respond very well to IV thrombolytics. So if he's still in thrombolytic window, probably medium vessel occlusions are better off with thrombolysis. Now, distal mechanical thrombectomy is technically more challenging and has probably higher risk of periprocedural complications. Now, this is very important to remember that there is almost no tissue besides intima and thin media. These are very fragile vessels. They are different from the peripheral vessels. So you've got to be very careful, otherwise they are easier to perforate. So we mostly use a sort of a J-shaped loop at our wire tip while we are advancing the wire into the cerebral circulation. We prefer not to keep the tip straight. So with that, thank you very much.